My name is Dr. Simon Kigondu. I'm a consultant obstetrician gynecologist and the Secretary General of Kenya Medical Association. I also serve as the chairman of Kenya Obstetrics and Gyne Society Central Branch. Today, I will discuss an issue of reproductive, maternal, neonatal, and health guidelines that were issued in Kenya in this COVID era. The Kenya COVID reproductive, maternal, and neonatal health guidelines were issued to enable continuity of reproductive, maternal, newborn, and family planning care services in the background of the COVID pandemic. Normally, we have guidelines that are issued that are not necessarily translated into practice. But these guidelines that were issued by the Ministry of Health in association with several partners, including the Kenya Obstetrics and Gyne Society, were issued as a practical guide for the continuity of reproductive, maternal, newborn, and family planning care services in the background of COVID-19 pandemic. And the COVID-19 pandemic was a new coronavirus viral disease that was highly contagious. It was reported to have been discovered, first identified in Wuhan, China, reported in December 2019. But the evidence gathered showed that routine practices came under threat due to competing demands. And the purpose of this was to simplify a way in which reproductive, maternal, newborn services would continue in the light of the pandemic. Generally, guidelines are given so that people can adopt them to their situation to be able to continue with services. The purposes of these particular guidelines in reproductive health were to identify the elements of antenatal care that were crucial to minimizing maternal and perinatal morbidity and mortality that required modification a bit to ensure the safety of patients and that of healthcare workers in the context of COVID-19. The guidelines also provided algorithms on intrapartum care for COVID-19 negative mothers, for COVID-19 positive mothers, and those who are suspected but not confirmed to have COVID-19 during labor and delivery, while ensuring the safety of the mothers, the newborns, and more importantly, also the healthcare workers. The guidelines were to identify the elements of postnatal care that would support women and that were crucial in minimizing maternal and perinatal morbidity and mortality. And that would require modification to ensure the safety of everyone in COVID-19. The guidelines would provide safe and highly effective care plans for women in acute emergency and urgent gynecological conditions that took into consideration the safety of patients and healthcare workers. The guidelines were also to ensure that family planning services and contraceptive services for women continued during the pandemic, and that we were able to respond to ambient and emergent sexual and gender-based violence that was expected to increase during the COVID-19 era. As part of management of COVID-19, the universal infection prevention measures apply. And therefore, for all reproductive, maternal, newborn health services, we need to continue with hand hygiene, frequent hand washing with soap and water, or sanitizing with alcohol-based sanitizers. Then you have respiratory hygiene, which includes consistent use of face masks in public settings, sneezing or elbows in a handkerchief, you cover yourself. Thirdly, you avoid touching the face, especially the mouth, nose, and eyes. It is said that the droplets on the hands could be transferred to the respiratory system via the mouth, nose, and eyes. Generally, people were advised to stay at home, and clinic visits were to be minimized in the context of reproductive health. We were asked to make more use of telemedicine, and to ensure that we keep what was called social distance, but is to keep a safe distance because droplet transmission occurs at a certain length from other people, especially in crowded places. In health settings, we are to reduce the number of visitors, including relatives who are visiting people requiring productive services. Should you feel sick, then like you get symptoms of fever, cough, difficulty in breathing, then advice was given that one should visit a designated facility for care. And as much as possible, you could avoid public transport where possible. And babies were to be left at home, especially when you are visiting a clinic, unless a clinic is both for the baby and the mother. And where possible, hospital visits where generally the number of people to hospitals was supposed to be minimized. And luggage was also minimized to hospitals. As you know, in reproductive health services, people do come with a lot of luggage, but these are fomites, and they could increase the transmission of COVID. The use of telemedicine in reproductive maternal health in the context of COVID-19 is that telephone calls were the preferred first contact with healthcare providers. The face-to-face visits were to be minimized. Then general inquiries on COVID-19 could be done through 24-hour call centers. The Kenya Medical Association, Nurses Association of Kenya also established a call center where health workers could also call in should they require services. There were issues that during lockdowns and emergency restrictions where medically appropriate evaluations could be done via telephone. And dedicated telecall centers where people would link between patients in one locality and another were also established. With that, people were able to actually minimize their visits to hospitals to necessary. For antenatal care, a COVID-19 infection is not an indication for the interference with natural progression of pregnancy. And therefore, the timing and mode of delivery remained the same based on obstetric and medical indications that were applicable. During COVID-19, pregnant women were not known to be more susceptible to COVID-19 than the general public. However, due to changes that occur during pregnancy, pregnant women may be more susceptible to viral respiratory infections. As is known, the immunity status of women who are pregnant may go down, and therefore they may be more susceptible to respiratory viral infection. It was important for pregnant women to protect themselves from illness and for their healthcare providers to have the most current and updated information to provide the best care for them. And many webinars came up teaching healthcare providers on the management of COVID-19. For clinic visits, care of the pregnant women is you're advised to highly individualize the care of expected women with respect to their status. In line with the recommendations to reduce the risk to both the client and healthcare workers, during the COVID time, the following recommendations were made: that clients should call their healthcare providers for advice that can be provided on phone by using telehealth before actually physically coming to hospital. Except where inevitable, patients would go to the clinic and they must wear a face mask. Clinic visits were reduced, and for face-to-face visits for antenatal mothers is considered a basic minimum, and supplementation with virtual or teleconsultation. Health workers should keep strict records of all visits, whether face-to-face virtual, preferably electronic, for medical legal purposes. Women suspected to be positive for COVID-19 should be safely transferred to and managed in designated level 4 hospitals and above, and they should be quarantined or isolated in centers that are managed by doctors. Referrals and consultations by telephone, video should be encouraged to minimize unnecessary exposure. During the antenatal screening, this is the testing while a woman is pregnant, they should be done at the first opportunity for every pregnant mother attending a clinic. And they should include universal laboratory investigations as are routine, HIV, hepatitis, blood count, syphilis, urine, blood group, and other baseline investigation for comorbidities and appropriate gestational ultrasound scans. Patients should be educated on danger signs, and every institution should inform mothers of what to do during emergencies and who to contact. When now the mother comes during labor and delivery, what is known as intrapartum care, health workers are the first responders to intrapartum care, providing frontline care and therefore risk their lives in doing so. Healthcare workers therefore should be equipped with the necessary information, like we are giving it, and protection to stay safe in the course of their clinical duties. All pregnant women need respectful, skilled care during the process of labor and delivery. To minimize risk, birthing partners in intrapartum units were discouraged during this COVID-19 pandemic, although one partner has been shown also to be important because the COVID and the birthing process are two separate incidences. All persons coming to the unit must be screened for symptoms such as fever, cough, shortness of breath, including a temperature check prior to entering the labor and delivery room, and every 12 hours thereafter, for potential exposure to COVID-19. Movement in and out of the delivery room must be controlled. Ideally, all persons in the delivery room should stay in the room until completion of the process for allowing non-return exits. So how do you triage mothers who are coming in? Always use the appropriate gear, the personal protective equipment before interacting with patients. The health worker is supposed to take a history and examine and investigate and cancel and review medication. In the era of COVID, we are specifically interested in hypertensive diseases of pregnancy, metabolic diseases, diabetes, endocrine disorders such as thyroid, cardiac diseases, respiratory diseases, hematological disorders, especially venous thromboembolism, neurological diseases such as epilepsy, gastrointestinal diseases like chronic liver diseases, rheumatic diseases, HIV, renal diseases such as CKD, and patients on renal transplant, and importantly, obesity. These are known to be risk factors in COVID-19, and it is important to screen for them. How do you care for a COVID-19 negative woman in labor? If we are expecting a normal delivery, the pregnant mother should have no complications, have previous normal deliveries, have no comorbidities, or if they have comorbidities, they are asymptomatic or have a mild disease. We need to monitor the labor as usual and conduct delivery as per set protocols of the unit. You need to use appropriate tools such as the pathograph, which is used for labor and delivery. And when the mother has been safely delivered and the baby, we need to be able to discharge as quickly as possible, and 24 hours after delivery is recommended. If the mother is delivering by cesarean section, these are like mothers who have labor complications, who have a recurring obstetric complication from their history, or they have planned pre-labor, which is a planned cesarean section, or have conditions that preclude them from delivering normally, then we would need to deliver by cesarean section as per protocols of the unit. And it is possible to discharge these mothers who have no complications within 48 and 72 hours of delivery. How do you care for the COVID-19 suspected confirmed positive mother? They have COVID-19 that has tested and it's confirmed. If they're expecting delivery, labor will be conducted in a facility with a quarantine or isolation room equipped for managing patients who test positive for COVID-19. Labor is monitored using the pathograph, and you ensure instrumental delivery is at hand in case of maternal distress, like they may have some respiratory lung issues during second stage of labor. Then immediate removal of the baby from the mother upon delivery to prevent contact until the mother has undergone the necessary hand and body hygiene. There's a delay in breastfeeding until the breasts have been washed with soap and water. Remembering COVID is a droplet infection that can stay on surfaces. The mother shall wear an N95 mask at all times during labor and delivery. This also includes the time they are in contact with the baby, and they should continue this at home until she has been declared COVID-19 negative. The staff assigned for the patient should be well trained, and they should be wearing the appropriate personal protective equipment as per the protocols. Currently, there is no evidence that there is COVID-19 transmission through breast milk. However, care should be taken not to expose the newborn. General staff should be trained on handling of patients who test COVID-19, and regular high-level disinfection of these quarantine facilities should be done. What of those mothers who are COVID positive and delivered by cesarean section? You need to obtain an informed consent. You observe the normal precautions for cesarean delivery and use designated negative pressure operating theaters. The patient should have a face mask, preferably an N95 at all times. Regional anesthesia is preferred unless these are contraindicated. As you know, we avoid droplets, and intubation involves droplets. All the prerequisite sterile procedures should be observed, and there is no contraindication to delayed cord clamping, which is recommended for for babies. Perform the cesarean section in the normal procedure. You delay breastfeeding until breasts have been washed with soap and water and the mother is wearing an N95 mask, and you restrict the staff who are assigned to the patient and control movement in and out of theater. A lot of facilities have their preparations outside the theater and only come into theater when the procedure is about to begin. And COVID-19 infection prevention measures must be observed at all times. Where intubation or general anesthesia is required, the rapid sequence induction using short-acting muscle relaxants preceded by generous oxygenation, bypassing the need for bag and masks, should be given by an experienced anesthesiologist. This is strongly advised, and the manual ventilation should use low tidal volume as guided by current anesthesia guidelines. The places with only one operating theater should fumigate immediately after the procedure is complete. And for postnatal care, healthcare facilities and healthcare providers managing women during the first 6 weeks after delivery, the main aim is to ensure that during the postnatal period, the risk of contracting COVID-19 infection is minimized. Women receive routine postnatal care, and women with emerging complications or emergencies are attended to appropriately and in a timely manner. The number of face-to-face visits should be individualized to meet the woman and newborn needs. However, where acceptable, you need to minimize the face-to-face visits for low-risk women who underwent normal delivery. You could review them after 6 weeks. For low-risk women, high-risk women who underwent normal delivery or cesarean delivery, we urge that you do individualized care. And any woman who complains of emerging complications must be triaged, risk profiled to determine the most appropriate care assigned to them. This can be done via telemedicine. So how do you assign risk? While keen on reducing face-to-face women, the following women should be considered high risk and accorded individualized care. One is women with medical conditions and other comorbidities during pregnancy and delivery, including gestational diabetes mellitus, cardiac diseases, hypertensive diseases, hemoglobinopathies, and venous thromboembolism, among others. Women with emerging complications during the postnatal period, including puerperal sepsis, postpartum hemorrhage, and postpartum eclampsia, and women with other medical emergency during the postnatal period. What are the appropriate levels of care for women? Women should continue to receive postnatal care at their regular healthcare facilities. However, in order to reduce the need for unanticipated referrals, the following recommendations were made. Low-risk women who underwent normal delivery and are otherwise well should be attended at lower levels of care, dispensaries, health centers, unless expressly advised. Unless necessary, women are advised to visit unaccompanied for obvious reasons. Women who underwent cesarean section and any woman classified as a high risk, irrespective of their mode of delivery, should be attended to at a higher level facility, level 4 and above, preferably in those higher institutions. Women with emerging complications during the postnatal period, including puerperal sepsis and postpartum hemorrhage, postpartum eclampsia, should be attended at the higher levels, level 4 facilities and above. Advanced telephone booking and scheduling of visits is preferred. Postnatal women confirmed or suspected to have COVID-19. The following principles are applicable. Case management will be according to the national guidance that are currently available for managing confirmed or suspected patients with coronavirus. Neonatal infant feeding options, while breastfeeding is advised and preferred, women will be counseled and guided on making the choice as to whether to continue breastfeeding or be separated from infants. There are guidelines on breastfeeding for this. Neonatal infant feeding options for postnatal women who are confirmed to have COVID-19. There is no evidence that SARS-CoV-2 is transmitted through breast milk, and therefore the benefits of breastfeeding outweigh attendant risks. Breastfeeding is therefore encouraged, but the efforts should be made to minimize the risk of contact and droplet transmission of COVID-19 infection to the breastfeeding neonate or infant. So the following options are recommended as appropriate. For safe breastfeeding options, follow the national guidelines, but we need to do strict hand hygiene and breast hygiene with soap and water and breastfeeding the baby. Use of N95 mask while breastfeeding. For separation from neonate or infant, which may be occasioned by severe illness in the mother due to COVID-19 or other complications that prevent her from continued breastfeeding, or where the mother chooses to separate from the infant, they may have fears of COVID-19, encourage the mother to express breast milk and maintain the milk supply. Ensure that the expressed breast milk is fed to the newborn by a healthy caregiver or a companion as is applicable, and when the mother is not able to breastfeed the baby. In the event that the mother is too unwell to breastfeed or express breast milk, appropriate breast milk substitutes such as formula milk and breast milk banks can be considered. So as we reach the tail end of the presentation, these are examples of algorithms that have been put as guidelines on what to do. So this algorithm is an antenatal clinic hospital outpatient care for all patients. And general measures to minimize exposure to patients and healthcare providers. You decrease visits for low-risk clients and supplement with telephone calls at scheduled visits. Number 2, you request patients to come to the clinic unaccompanied unless it is inevitable due to illness. At the clinic, you screen for symptoms of exposure to COVID-19 over the phone before arrival at the clinic. If they are negative for COVID-19 or the test is not feasible, then you proceed with the visit as scheduled. If they are screened and confirmed to be COVID-19, then you assess whether the visit is necessary for maternal or fetal reason. If it's not, then you advise on precautions, social distancing, masking, and hygiene. Notify the team on use of PPE and link to a designated facility. If you are able to defer the visit for at least 14 days, do so, and advise the patient to monitor the symptoms and indications before they present to the emergency room. Then you share the hospital or facility telephone number. You need to screen all visitors at the main entrance of the clinic, of the hospital, for fever, cough, breathing difficulties, and to do contact history. And once you've done that, if you have people who screen negative for COVID-19, then you can educate them on prevention measures. And if you have patients who screen positive for COVID-19, then you need to identify the patient, prioritize this patient, and minimize their stay at the waiting area. The patient must be having on a mask at all times, and they must be the attending team, the people who are seeing this patient, must be having the appropriate personal protective equipment. You need to assess them for any severe symptoms so that you are able to transfer them to a unit where they can be taken care of. This second algorithm is the algorithm used for intrapartum and postpartum management of expectant ladies. You need to screen all patients again and limit the number of visitors. Then if they are negative for COVID-19, routine intrapartum care with limited visitors is done. If they are positive, then you need to manage them in a specialist hospital, which has an isolation unit or designated specifically for COVID-19. You identify the patient who screened positive, notify all the staff that the client is COVID positive. The patient needs to wear a mask at all times and observe hand and respiratory hygiene. And you need to assign team leaders to coordinate with the labor ward, the anesthesia team, the newborn unit, and the infection prevention teams. And any C-section should be performed using standard precautions for COVID-19 plus for the cesarean section themselves. So the third algorithm is one for neonatal care for women with suspected or confirmed COVID-19 positive, who is COVID-19 positive. And the algorithm repeats what we have gone through the presentation and puts it in a flow chart and easy to understand way. And this is one of the benefits of having protocols. Then the final algorithm is one for case management for sexual and gender-based violence. As we are aware, during COVID-19 and periods of limited movement and people staying in together for long, there has been reported cases of increased sexual and gender-based violence, and people would need to know what to do in case of sexual and gender-based violence. So patients at the entry of a health facility need to be having a face mask and observe infection prevention measures. They are screened positive for COVID, need to isolate them and notify the IPC team and the gender-based violence service team. If they screen negative, if they screen positive for violence, then you offer post-gender-based violence care packages. You assess for gender-based violence risks at home and community and design a feasible follow-up plan for them. If they don't screen positive, if they're negative for violence, you advise them on social distancing, masking, hygiene, and assess what the risks of gender-based violence at home and the community are. So with that, we have a generic screening tool for maintenance at a hospital or a clinic facility, and this captures all the details and screens people entering quickly into the facility and discriminates between those who may or may not have COVID-19. But in an era where it is a panic, it must be assumed that all people have the capability of being positive for COVID-19. So the screening tool has places where you can tick for cough, difficulty in breathing, hotness of body, sneezing, headache, general body malaise, and it can be modified to any facility to increase the chances of detecting COVID-19. And with that, we want to thank you and hope that you are able to individualize the RMNH protocols within your institution, and also for individual healthcare workers, they can also take bits and pieces of it to run their clinics. Thank you very much.